Today's topic is on defense mechanism of gingiva. The oral cavity is a harbor of microorganisms that is varying about nearly 700 species of bacteria. It keeps facing a day-to-day challenge from these microorganisms and also various mechanical aggressions too, like toothbrushing or eating a hard substances or all these things. Do you think that gingiva in particular is going to sit back and allow these aggressions to take over it, or it is going to stand still and going to face it, and of course it is going to defend it and protect it? But the question is how. It is the initial inflammatory response that is shown by the gingiva and the periodontium to protect against these forces or adverse effects. So the junctional and oral cellular epithelial surface, the saliva with its enzymes and immunoglobulins, the gingival crevicular fluid, the GCF, with its cellular electrolytic and organic compounds, they form the defense mechanisms of the gingiva. So, moving on to the topic, before going to the topic, we should know the difference between transudate and exudate. So, by definition, transudate is a filtrate of blood plasma without changes in endothelial permeability, which generally occurs due to hydrostatic or osmotic changes, whereas exudate is an edema of inflamed tissue associated with increased vascular permeability. The color of transudate is clear or pale yellow, while that of exudate is cloudy yellow or bloody in nature. Whereas the character is non-inflammatory in transudate, and exudate is generally an inflammatory in nature. The transudate doesn't coagulate, whereas exudate coagulates. Transudate has got a scanty appearance of cells, while in exudate you can observe numerous cells. The protein content is comparatively low in transudate when compared to that of exudate, and specific gravity is less than 1.015 of a transudate, and it is more in exudate. So gingival, the question here is gingival crevicular fluid, is it a transudate or exudate? Yes, it is also called a circular fluid, but what is it? It is an altered serum transudate found in gingival sulcus as stated by Genco. And few other experiments done by Dr. Brill also confirms that it is a transudate. But there are some other authors who still contradict, stating this as an inflammatory exudate. Strictly in normal gingiva or a healthy gingiva, there shouldn't be any fluid collection. But here we could see a gingival collection. So hence it is nowadays it is considered as a inflammatory exudate. How to understand the, since it is an inflammatory procedure, inflammatory exudate, it has got various components that can be examined, and so that you can determine whether the gingiva or the periodontium is in a healthy state or in a disease state. So these are the methods to collect the GCF. So there are basically two methods: intracellular method or the Brill method, and extracellular or Lowenholm Pedersen method. As the name suggests, intracellular, it means whatever the device or the material which we are going to collect the GCF, it is placed deep inside the sulcus till the base of the gingiva. Whereas extracellular, the device will not go completely inside the sulcus, whereas it is placed within the sulcus, but it is not invading the sulcus. And here we can see, like, there are two methods of taking it. As it shown in the B, it is gone inside the sulcus, but it is not touching the base of the gingiva. And in C, it is folded in a such a way that it follows the contour of the gingiva. So, what are the aids? In what ways you can collect the gingival crevicular fluid? We can use absorbent paper strips, as we can see the orange and white strip in the figure in the top left top left figure, and we can use a pre-weighed twisted threads. These threads are weighed and then they are inserted into the sulcus using a probe or a blunt instrument, and the it is held in the place for 20 to 30 seconds, and these threads are removed from the sulcus and then weighed again. So the difference amount is the amount of gingiva that is gingival crevicular fluid that is collected. And the other method is the micropipettes. These are the calibrated micropipettes. As we see here, the markings, the initial will be, they will be taken in microliters. So the micropipettes, it is placed near the at the junction of the gingiva and the tooth. So through the capillary action, the gingival crevicular fluid that is leaked will enter into the micropipette. And the intraclavicular washings, this two tube device with two tubes, that is a hollow uh, a tube within a tube is inserted into the gingival sulcus. The inner tube, it acts as a pump. The outer tube acts as a suction, as we can see here in the right bottom corner of the slide. Through the inner tube, the saline is pumped. So the saline enters the gingival sulcus, and whatever the cellular structures or the gingival crevicular fluid present in the sulcus will be uh, will be taken out using the suction tube. So this is another way of collecting the GCF. So if we observe, absorbent paper strips and twisted threads, they are intracellular method of collecting GCF, whereas micropipette is an extracellular method. Even the crevicular washing is again intracellular method. So, how to determine the amount of GCF collected? As we have seen before, the gingival, a pre-weighed twisted threads can be inserted into the sulcus, and the amount of difference can be taken it as amount of GCF. Otherwise, a ninhydrin staining can be used to determine the amount of GCF from the absorbent papers. The amount of stain that is taken by the GCF will be taken as a visual recording on a visual spectrophotometer, or the amount of dye that has been taken is taken as a optical density measurement. That's how the amount of GCF will be calculated. And periodron is a electronic instrument that weighs the minor quantities of GCF. So, what does this gingival crevicular fluid contain? So, these are the common the cellular elements, electrolytes, and organic compounds that are generally observed in GCF. So, we can take an anonym of CEO to remember it quick. We can remember this as CEO. Under cellular elements, bacterial cells, desquamated cells, and leukocyte cells are observed. Whereas under electrolytes, sodium, potassium, calcium can be seen. In organic compounds, the most common things that are observed are carbohydrates, proteins, glucose, lactic acid, urea, hydroxyproline, endotoxins, and hydrogen sulfide. So, how are these components determined? Just having the components is not useful. So, these are generally determined using enzyme linked immunosorbent assay or radioimmunoassay and high pressure liquid chromatography. So these are the other products that are observed in gingival crevicular fluid, like host derived enzymes and their inhibitors. Under these, aspartate aminotransferase, alkaline phosphatase, acid phosphatase, beta glucuronidase, elastase inhibitors, alpha 2 macroglobulin, alpha 1 proteinase inhibitors, cathepsins, cysteine proteinases, serine proteinases, and cathepsins comes under host derived enzymes. There will be tissue breakdown products during the inflammation. during the battle between bacteria and the host response. So these products, the during that battle there can be some tissue breakdown products, or these tissue breakdown products are in general, it's a part and parcel of the regulation and harmony of the in general cell environment. So glycosaminoglycans, hyaluronic acid, chondroitin 4 sulfate, chondroitin 6 sulfate, dermatin sulfate, hydroxyproline, fibronectin fragments, osteonectin, osteocalcin, and type 1 collagen peptides, osteopontin. All this comes under tissue breakdown products, inflammatory mediators, and host response modifiers. Under these, cytokines, interleukin 1 alpha, interleukin 1 beta, interleukin 2, interleukin 6, interleukin 8, TNF alpha, interferon alpha, leukotriene B4, prostaglandin E2, transferrin, and lactoferrin, and immunoglobulins like G1, G2, G3, G4, IgM. All these are observed in gingival crevicular fluid. Moving on to the clinical significance. So circadian periodicity, it generally the more amount of gingival crevicular fluid is observed in the circadian periods of 6 to 10 a.m. So generally, whenever there is a surge in sex hormones, there will be a increase in gingival crevicular fluid. That is the reason we tend to see more amount of inflammation in case of pregnancy, in pregnancy situations, or at the time of puberty, or during menstrual cycle, during the regular menstrual cycle. The gingival crevicular fluid, the flow will increase even with mechanical stimulation, like for example, whenever we eat hard foods like carrots, or even during the time of brushing also, the flow of GCF will increase. It was actually observed that there will be a transient and immediate increase in gingival crevicular fluid with smoking. And whenever there is a whenever the periodontal therapy is performed on a patient, there is an increase in gingival crevicular flow. So, these are the leukocytes that are present in dentogingival area that aids in defense mechanism of the gingiva. So, 91.2 to 91.5% of the leukocytes are polymononeutrophils, and 8.5 to 8.8% are mononuclear cells. Among the mononuclear cells, 56% will be B lymphocytes, whereas 24% is T lymphocytes. Generally, the B lymphocyte to T lymphocyte ratio is 1 is to 3 in GCF, whereas 3 is to 1 in the blood. That is how GCF is different from blood. So, um, moving on to the saliva. Saliva is a clear, slight acidic mucoserous exocrine secretion. Its average daily flow is around 1 to 1.5 liters, and whatever the saliva that is produced, 20% is from parotid gland, and 65% is from submandibular gland, and 7 to 8% is from sublingual glands, and less than 10% is produced from numerous minor glands. On an average, unstimulated flow rate is 0.3 milliliter per minute, whereas stimulated flow rate is 1 to 2 ml per minute. The normal pH of saliva is 6 to 7, meaning that it is slightly acidic. What is a saliva composed of? It composed of 99.5% of water and 0.5% of solids. So under solids, it is again divided into organic, inorganic substances, and gases. The organic substances are comprised of enzymes like amylase, maltase, lingual lipase, lysozyme, phosphatase, carbonic anhydrase, and kallikrein. And the other organic substances include mucin, albumin, proline rich proteins, lactoferrin, IgA, blood group antigens, free amino acids, non protein nitrogenous substances like urea, uric acid, creatinine, xanthine, and hypoxanthine. Sodium, calcium, potassium, bicarbonate, bromide, chloride, fluoride, and phosphate comprise the inorganic substances, whereas oxygen, carbon dioxide, and nitrogen are the gases that are generally seen in saliva. Normally, glucose is absent in saliva, but it is found in saliva during diabetes mellitus. So, what is its role in oral health? So, how is it acting as a defense mechanism? So, saliva helps in lubrication by its component with its components like glycoproteins and mucoids. Generally, these are the common mechanisms that maintains the gastric mucin. Also, it is a coating similar to the gastric mucin, whereas it acts as a physical protection too with the help of again glycoprotein and mucoids. It aids in cleansing because of the physical flow of the saliva. There will be a clearance of bacteria and debris that aids in cleansing. The bicarbonates and phosphates with its anti-acid mechanism allows the saliva to help in buffering. The minerals the minerals helps in remineralization and maturation, thus helps in maintaining the integrity of the tooth. The components like immunoglobulin A, lysozyme and lactoperoxidase, they control the bacterial colonization. They also aids in breaking the cell walls of bacteria and oxidization of the bacteria, thus helping in antibacterial action. So, what are the antibacterial properties? The lysozyme, it is effective against the most common periodontal bacteria like AA, that is Aggregatibacterium actinomycetum commitans, and the Valionella species. The lactoperoxidase thiocyanate system, it is bactericidal to lactobacillus and streptococcus species of bacteria. The myeloperoxidase enzyme that is released by leukocytes is bactericidal for actinobacillus and inhibits attachment of actinomyces strain to hydroxyapatite crystals. The salivary antibodies like IgA, it is more common in saliva. The IgA is the predominant immunoglobulin of saliva, whereas immunoglobulin G and M, the immunoglobulin G, these are also observed in saliva, but IgG is more prevalent in GCF. The IgG and IgM helps in opsonization of the bacteria. There are living polymorphoneutrophils in the saliva, which are otherwise called as orogranulocytes. Apart from that, there are some other clotting factors, that is clotting factor 8, clotting factor 9, clotting factor 10, and plasmothromboplast antecedent. These are the clotting factors that are present in saliva. There is the antihemophilic, Christmas, and the Stewart-Prower factors that are observed in saliva. That is the reason, even though we tend to see any wounds in the oral cavity, they tend to heal quite quickly. So, to summarize the actions of the saliva, it has got an antifungal action because of the histatin 5, beta defense, and cathalycidins. It shows the properties of wound healing because of the presence of growth factors, histatins, secretory leukocyte protease inhibitor, trefoil factor, and leptins. It acts as a buffering agent because of bicarbonates, phosphates, and proteins. And it aids in teeth mineralization with the help of histatins, proline rich proteinase, and statherins. It also allows the food digestion because of the enzymes present in it, like amylase, mucins, and lipase. It coats the and lubricates with its enzymes like amylases, cystatins, mucins, and proline-rich proteins and statherins. It has got antiviral properties because of cystatins and mucins, and antibacterial properties because of its amylases, cystatins, histatins, mucins, and peroxidases. Thank you.